All right, welcome to the July meeting of the West Virginia Food is Medicine Coalition. Um, Hillary, I think we're starting off with you today, so I'll hand it over to you.
All right. Welcome, everybody. My name is Hillary Payne. I'm the director of the Division of Health Promotion and Chronic Disease at the West Virginia Department of Health. Ryan, if you want to advance to the next slide for me. Again, thank you for joining us for our July meeting. If you will take a minute to drop your name, your organization, and what county you're in the chat so we can have a record of who all attended today, that would be great. And Ryan, you can go to the next slide. While you guys are putting your info in the chat, I'll go over our objectives for today. We want to provide an overview of the national food as medicine landscape. We want to build confidence in this initiative, make food as medicine work tangible, acknowledge concerns about failure and unfulfilled promises, and set some realistic expectations. And so with that, Ryan, if you want to go to the agenda. Next, we're going to share some updates about things the steering committee have been doing in the background. And then we also have a provider spotlight on the Southern West Virginia Food as Medicine Coalition. We've got a presentation and discussion. That'll be the overview of the national food as medicine landscape with Kristen Sukis. And then we're going to do a quick wrap up to end the hour. Thank you, Ryan. So again, if you'll use the chat function and put in there what questions and or concerns about food as medicine work that you have personally or within your organization. And while you guys are doing that, I'll know we may not answer all of those questions today, but this will definitely inform discussions and presentations that we might have in the future. So I'm going to give you guys a second to do that. And you can keep adding to the chat as we move on as well. All right. And with that, I'm going to turn it back to Ryan.
Thanks, Hillary. Yeah, definitely keep those questions coming in the chat. We want to, document as much of those as we can. To better partner with you all. So we're going to just go to the next slide and just touch base on a couple save the dates. We are going to be having an in-person meeting for this coalition in September. That's going to be at the Stonewall Resort. And it's going to be 10 a.m. to 4 p.m. with an optional sort of like coffee networking before 10 a.m. That morning. We will be sending out more detailed information about an agenda, what to expect on that, and RSVP information that will include information about securing hotel rooms that we've put a block on. And that information will be sent out early next week. So just so that's on your radar, and just getting excited. Believe it or not, September's right around the corner. My grandmother always said summer ends after the 4th of July. So too real. But also on July 23rd, we are going to be hosting a focus group specifically for those of you who are focused on philanthropy. Those of you who joined us last month will remember we did a quick survey asking you all to sort of self-identify which different sectors of work across the food as medicine landscape that you touch or have expertise on. So we would like to invite those of you who are focused on philanthropy to join us for a tailored small group discussion on the 23rd. And that invite's going to go out. But if you're in the room today and that sounds like something you'd be interested in participating in, drop your email in the chat. Let us know, give us a shout out, or maybe even just raise your hand. And we'll make sure that you get an invitation to that directly before it gets sent out in more targeted outreach. So more information, save the dates, calendar holds will be coming out for those. And I'm going to hand it over to Mirinda to move us along. So I know we got a lot of great content coming up for you folks.
Thank you, Ryan. I'm the Director of Health and Community Education at Family Care Health Centers, and we wanted to give some feedback. We had sent out a survey asking where participants were, what participants were interested in doing. And so we kind of just broke it apart into different sections. And so we wanted to show that. So program design and implementation and community engagement and collaboration were the interests that people were most interested in. We did also have local agriculture integration as another interest. And then funding identification and education and training were also close. The other ones that we discussed were care management and referrals, research and evaluation, policy development and advocacy, and a centralized system for food as medicine administration. So we did have a good results on those surveys. So thank you for those of you that participated in that. And you can go to the next slide. And then we wanted to introduce, so we just recently were introduced to a Southern West Virginia Food as Medicine Coalition. And so I have invited Danielle Harmon, who's the Community Development Director of Appalachian Regional Healthcare, to just take about 5 minutes to tell us that the work that they are doing, and we're excited to hear about that. So Danielle, I'm going to turn it over to you.
Sure. So thank you guys so much for having me. I am so very excited to see that this is already working across all of West Virginia. So we are a 14 hospital healthcare system that covers Eastern Kentucky and Southern West Virginia. We have sites there in Summers County, in Hinton, and Beckley and Riley County. And then we also serve all of our surrounding counties there as well as our secondary service areas. And then we have really done a ton of food as medicine in Kentucky, and we're really interested as Appalachian Regional Healthcare to expand into West Virginia, some of the programs that we have already been doing, and really trying to figure out what the landscape looks like over there. We've had some meetings with the Department of Agriculture as well. And so kind of what we've done in Kentucky is blend together food as medicine and agriculture with the Department of Ag, some farmer support programs, and a few other things. So first and foremost, I should say, I'm Danielle Harmon, and I am the Director of Community Development for ARH. So what that means is all of our community-facing programs, our health education, cooking classes, our awareness events, anything that can be counted as community benefit for our 990 to keep us as nonprofit and give back to our community in a ton of different ways. Food as medicine has really been very, very important to us in our leadership over the past 3 years. So we started at the bottom. We have a nice little food as medicine continuum triangle, the same that you guys have all seen, I'm sure, that we do a little bit of everything for our communities and our patients. So starting at the bottom, we screen all of our patients that come in, of course, from CMS requires on that on inpatients, and we are getting our outpatients and our clinic patients screened as well for food insecurity. We have an in-facility food box program in all of our Kentucky regions, so we're trying to give those food boxes to anybody that comes in and says that they're hungry. We know there's a huge tie, of course. Food as medicine is not just food insecurity, but there's a huge tie for both of those. So trying to meet the needs of our food insecure patients. And then moving up our continuum, and I'll share a nice little PDF for you guys. It's like our update for July and all the things that we have done, and also has my contact information on it. But moving up the continuum, we also have some population level healthy food programs. So we support farmers market voucher programs. We have a program with some community health workers in Harlan County, Kentucky, where we support the purchase of fresh fruits and vegetables for seniors that are income eligible. And then out of that, they are case managed. And we've seen ROI for like $70-ish for every $1 spent there in medical services and things like diabetic shoes and vision help and all of those things as well for those seniors. So trying to use food as kind of an incentive as well. And then at a population level, we also have healthy cooking classes all throughout Eastern Kentucky, a couple places in Southern West Virginia, very interested in broadening those classes. And then we do medically tailored meals as well for our diabetes support group patients. So anybody that comes to our diabetes support groups, we have some grant funding from the Palatine Foundation, which works in Southern West Virginia as well. If you haven't heard of them, they're fantastic. And with that, we were able to purchase the food boxes for anyone that comes in that has diabetes and attends our support groups. They learn how to make a meal and then take all of the food home to make that meal at home for their families as well. And then we also have a program that we have participated in, I guess, for a couple of years now with the University of Kentucky, actually registering our patients with diabetes or type 2 diabetes or hypertension to sign up to receive 12 weeks of medically tailored meals. And so we saw out of that program, we've gone through 2 cohorts, and we had some great outcomes when it came to lowering hypertension and lowering A1C as well. So a ton of different stuff. I won't go on forever. It's a lot to learn about, but I'll happily share this PDF, and I have some slides that I can share as well. Mostly, I'm interested in being here in this group because we wanted to make a Food as Medicine coalition and then learn that you already had one. So it's amazing. I'm so excited that the work is already ongoing. And so I don't want to duplicate what you guys already have going. If it's something that's needed in Southern West Virginia, we of course will take up that gauntlet and make it happen. But I really am interested in learning what you guys already have going, seeing if there's any ways that we can partner throughout Southern West Virginia. And then I think somebody I saw was here from the Department of Agriculture too. So we'll kind of talk through what that means and how we also try to support our farmers. So I know that I think I'm over my time, so I'm sorry. It's a lot of stuff.
You're fine. That's exciting. A lot of things. But all wonderful.
Thank you. And I'm going to drop that PDF in the chat.
Okay. And I think I'm going to turn it over to Gina.
Yeah, thanks, Miranda. So I just have a few comments about our capacity building efforts. I know during our last meeting, there were several questions about funding, where are we with funding and what are our plans regarding funding? So we do have some existing funding sources. We have high obesity prevention grant funding that is a CDC funding source that runs through the College of Applied Human Sciences at WVU. So we have some funding from that grant, very generous of them, that will end in September of 2025. So just about 3 months from now, we have an AARP grant, which actually kicked off in January of this year and will take us through about January of 2026. We did apply for, and I think I shared this at the last meeting, or it was shared at the last meeting, we applied for preventive block grant funding through the Bureau for Public Health. That is also a CDC funded effort. Unfortunately, we learned a couple of days ago that we weren't selected to receive that award. So we are seeking funding to maintain and sustain our capacity building efforts. So if anyone out there, we're looking now, so we're obviously on the hunt for funding sources to keep this coalition building work going. So if anyone out there is aware of a planning grant, a capacity building grant, or other opportunities that would allow us to continue to build our coalition and to develop our strategic plan, we would be so very grateful to be alerted of those opportunities. The other thing we want to mention really quickly is that we do have, through the CDC HOP grant, we have a relationship with JJN Multimedia, which is a local West Virginia multimedia company. They are going to help us with our logo, branding, social media, website, and some other assets. So we are going to be working with them very quickly from now through September to develop some of those things. So we're going to be excited, hopefully, to be able to roll out some of those assets at our August meeting, which I think will be August 14th, and share those with you for some feedback. So I think those are all the capacity building updates that we have today. And I'm going to turn it back over to Miranda.
Thank you, Gina. I'm excited to see what JJN comes up with. We're very excited about developing the logo and the material that they're doing. So I'm going to turn it over. We are very excited today to have Kristen Sukis here, and she is an expert in food as medicine, has worked in policy, has worked in multiple states. I'm going to let her talk. She would do a better job of explaining what all she's done, but we're really excited to have her. So Kristen, I'm going to turn it over to you.
Great. Thanks so much, Miranda. Hi, everybody. I'm Kristen Sukes, and I'm the founder of Food is Medicine Strategies. I'm a one person freelance consulting firm that is focusing on kind of movement building, particularly at the state level across the United States to increase access to food as medicine services. So I've been working in the food as medicine space for about 7-ish years. Um, I went to graduate school in Boston for actually agriculture. And so my background is kind of broader food systems work. But after graduate school, I actually ended up working with the Center for Health Law and Policy Innovation of Harvard Law School. And I joined the team right when that particular team was working on the first food as medicine state plan in the nation. So I joined them right when we were completing 2 years of data collection. So coming in and starting to learn about food as medicine, analyzing that data from, we collected things from CBOs, community-based organizations, kind of decision makers and policy makers, healthcare providers, healthcare payers. And really, we did that to figure out, well, what are the barriers in the state? First of all, what's the need for food as medicine in Massachusetts? But also, what's the barriers in the state that we need to think about in order to increase access to those? And then after we published the Food as Medicine State Plan, which I will drop the link in the chat, we then realized that we needed like a body, a coalition to kind of move all that work forward and implement that. So we launched Food as Medicine Massachusetts. And, it was kind of fantastic the way that we did that because we had relied on so many partners across the state to develop this Food as Medicine state plan. And so we already had a lot of investment in this movement. And so we launched the coalition. And, there were a lot of lessons learned there. But it is still functioning and going strong today. There's a lot of stories that I can tell about the growth and development of the Food as Medicine Massachusetts Coalition, but it was very successful. And so from that success, the Center for Health Law and Policy Innovation, affectionately known as CHILPI, started providing technical assistance to groups in other states as well that were interested in forming coalitions to support food as medicine. When COVID happened, I actually ended up moving out to Seattle, Washington, and I ended up leaving my position at CHILPI. But since then, I've been providing similar services in a freelance capacity. So far, I've been involved in efforts in DC and Maryland and Indiana, Kansas City, spanning Kansas and Missouri, and then Michigan as well, and recently got connected with everybody in West Virginia. So I'm really excited to launch this work here. I also, outside of like particular state level technical assistance, I also led the National Produce Prescription Collaborative State Policy Working Group for a number of years. And then most recently, I also was a project manager for a big initiative called Coding for Food, which is through the Gravity Project and a group in California, developing definitions for food as medicine services and then applying to CMS to get HCPCS codes or medical codes that align with those definitions so that we can work to standardize these interventions across the nation. Thank you so much, Mark, for dropping that in the chat. Some other points here before I dive in. My role today is to really contextualize West Virginia's food as medicine efforts in the broader landscape. So I'm going to go over some things that many of you already probably know, just to make sure that we're on the same page here. And my goal is to really just kind of tell you the story of food as medicine and ground us in where we are today. So I'll talk a little bit about the concept, but I'll also talk about the growth of the evidence base, state coalitions, of course, and then some federal policy changes that have both facilitated and then sometimes inhibited food as medicine, and what the challenges that we're faced with today are as well. So it's going to be a lot. I recognize that. These slides are dense, and there's a lot of links on the slides as well. So this deck is intended to be a resource for you all, and really just kind of whet the palette here so that we can talk about what are the things that we're interested in, what questions do we still have, what's the relationship between West Virginia and the national landscape, etc. So slides will be shared, and I will pause at the end. Before we get going, though, I would love everybody, I would really like to get a read on kind of where people see themselves in their knowledge of food as medicine. So if you could be so kind as to put, think about how you feel about your knowledge of food as medicine. And I'm going to ask folks to put a number in the chat between 1, feeling like this is a brand new concept to you, to 10, feeling like you are a very extremely knowledgeable about what's been happening, especially in the policy front and the policy pathways that are available for food as medicine, or even the landscape. So it's a choose your own adventure, however you're defining this, but I'm really curious where everyone is landing on your particular knowledge of food as medicine. Awesome. We have a lot of 6s, some 5s, middle of the road. Fantastic. This is a great spread. Thank you so much. Keep those coming too. Oh, Tyler, 7.2. Love the decimal. Encourage that all around. All right, folks, keep them coming, and I'm just going to launch in here. So we know the stats of West Virginia. You all know the stats of West Virginia. West Virginia has some of the highest rates of chronic conditions in the nation. We have about 16% of the population with diagnosed diabetes, 40% of the population with obesity, 44% with hypertension, 41% with high cholesterol, and also about like half of the population suffers from long COVID as well, those with COVID, I think. But then also when we look at kind of just the spread of chronic conditions at large, we have close to 3/4 of the population of West Virginia that has at least one chronic condition. But then we have about 1/3 of the state that has 2 or more chronic conditions. And we know that these multipliers are really hard to navigate, to manage, and of course to experience as well. We also know that West Virginia has some of the highest rates of food insecurity in the nation too. Different statistics are kind of between 13 to 15% right now, but that's what we're finding, which is pretty high. We also know that nutrition security, kind of just looking at healthy food access and healthy food consumption, is also a bit of a challenge here in West Virginia too. We have about half of the population, according to the ERS, eats less than a serving of fruit a day. And then we also have 1/4, according to the ERS, that is eating about 1 serving or less than 1 serving of a vegetable per day as well. We also know that one out of 6 West Virginians uses SNAP. So actually, West Virginia has a fantastic SNAP enrollment. I think it's like 98%, 97%. Folks on the call can let me know for sure, but a lot of people that are eligible actually participate in the program, which is absolutely fantastic. We also know that there's challenges there that are coming down the pike, which we'll talk about soon. The other thing is, what does our food environment look like in West Virginia? A lot of folks live in rural counties. We know there's challenges with grocery store access and food access out there. And maybe when grocery stores are available, it's challenging sometimes to keep fresh stock of produce in. And when it is in, sometimes it can be fairly expensive as well. So there's a lot of factors that West Virginians are struggling with here or challenged with. And we also know that all of this is pretty expensive. So there's a wonderful study I always like to cite, which is from Seth Berkowitz from 2019. And that really looks at the association between food insecurity and healthcare costs. So in West Virginia in particular, his model has shown that food insecurity equates to about 327 million in healthcare costs annually. I know that's a huge number. I highly, highly recommend that you take a look at that study. I can share the link later. But really, when we dive into that, we're also seeing that per capita, that's a rate of $177 per person. So West Virginia kind of comes in about the 10th highest for the per capita rate in the nation. We also know that diabetes is very expensive. It's a pretty big burden on the state expenditure and budget. So in West Virginia, I think it was the American Diabetes Association from a recent publication in 2024 associated diabetes with, close to $1.7 billion in direct healthcare costs. This was from 2017. But then, of course, when you add in a loss of productivity, it just balloons. So it is kind of an unimaginable, all of these numbers are just completely unimaginable to really feel. All total, there's been a range of estimates here, but estimates have shown that total chronic conditions and the cost of those chronic conditions in just direct medical costs equate to about $10 to $24 billion annually in West Virginia. I think I looked up the complete budget of West Virginia, but I forget right now, but it is a substantial percentage of that. So, we had Danielle that just talked about the food is medicine pyramid, and I know that you all have talked about it, and everyone has probably seen this before, probably to an exhaustive amount. But, when we talk about food as medicine, or when I talk about food as medicine, I talk about a very distinct set of interventions. There's probably a few more that I would probably add onto this pyramid at this point, but primarily it's the ones in the box at the top: medically tailored meals, medically tailored groceries, and produce prescription programs that we are aiming to get healthcare reimbursement for. So these are specific interventions that are associated with food insecurity and very specific chronic conditions. And of course, the pyramid goes from prevention to treatment. And we also have an expectation that there is nutrition education and counseling going along with all of these interventions as well. We know that now we also have medically supportive meals, medically supportive groceries too. That depends whether there's a registered dietitian involved in the tailoring of those meals or groceries or not. Yes. I also wanted to give a brief background of this concept of food as medicine, just because I think it's important. And we know that this idea of food being integral to health goes well beyond the 80s. We can talk about Dr. Greiger from the 1960s, and even before that with indigenous communities and just the history of our world. There's always been this understanding and connection of how food and nutrition plays into our general well-being and, of course, our physical health as well. But the idea of these like really tailored interventions really started in the 1980s with the HIV and AIDS epidemic. And when folks were dying from AIDS wasting syndrome, the focus then was just getting calories to folks. And so that's when the birth of the medically tailored meals, organizations really started. And their mission was just feeding people and making sure that they had enough to eat. And of course, then we had these antiviral drugs, which we learned were the most effective when somebody was nutritionally sound. So that was the first kind of big connection between like, oh, well, we need somebody to be nutritionally sound in order for this medical intervention, this medication to be really, really effective. But of course, today, and and especially the last, let's say like 8 years, food as medicine has really grown and grown and grown. And, today it means a lot of things. It's also kind of this bigger umbrella and, a kind of a rebranding of nutrition at large. But we're still staying pretty grounded in defining it as these interventions. So recently, we had Rockefeller and the American Heart Association getting extremely involved and dedicating a lot of funding to this space, especially regarding research. Rockefeller has, I think they're well over 100 million at this point, but that was a recent announcement. We also had a big issue of health affairs that was specifically dedicated to food as medicine that came out in April or last April, recently, over the last year. Which is huge. I highly recommend everyone go check out that issue. It is chock full of fantastic articles and food for thought. We also have national publications and journals like the New York Times publishing articles on food as medicine. Similarly, we had A lot of movement from the American Heart Association. We have the federal government, which especially in the Biden administration was getting really involved and extremely supportive of food as medicine. The national strategy, individual offices and departments were kind of going through their own strategic planning around food as medicine. There is a lot there, no shortage of things. Of course, we also have the Gus Schumacher Nutrition Incentive Program, the kind of biggest federal funding that goes to support produce prescriptions across the country as well. So, there's a lot of reasons why, or a lot of things that have been happening that has led to this growing support of food as medicine. And they're all happening at the same time, but I'm going to break them down into three different kind of distinct buckets. And the first is really this growing evidence base. It's growing in numbers. It's also growing in rigor. The way that those studies are conducted are becoming, more standardized, a lot more RCTs, so stronger studies as well as more studies. So I can't give all of the information here, but I did want to pull this image from the Tufts True Cost of Food report that came out that focused on food as medicine. And specifically because, we know the impacts that these interventions can have on health. We're still learning that too. But I think we're also seeing a lot of research in the policy sphere and then also connecting these interventions to healthcare cost savings, which we know is of national attention and local attention as well. So we have two case studies that are highlighted in this report. The first is about the impact of medically tailored meals on hospitalizations and healthcare expenditures. And then we have the second case study, which is all about produce prescription programs and the health and economic impacts of those two. So what's not highlighted here, especially in the produce prescription space, is really the impact on the local economy as well, which we know is profound. But with a more tailored interventions like medically tailored meals, we know how much these interventions can save in healthcare costs. We know how much these interventions help patients as well, and you can see that in the hospitalizations too. So this is a great one if you're trying to contextualize what do these interventions mean for healthcare. On the right, there's no way I'm going to go over this, but again, these are reference slides. These are some of my favorite articles or studies or reports that give an overview of research. I'll also say specifically, and I had this one pulled up too, but the Aspen Institute just released a new version of their Food as Medicine Research Action Plan. And that is a fantastic overview of where that just came out in 2024. So pretty up to date, fantastic overview of where the evidence base currently stands, where there's opportunities to improve the evidence base and strengthen it. But it also just provides an overview of what we know so far. So, the second factor in kind of this rising tide around food as medicine is really some incredible movement at the state level. So we have movement building, and then we've seen a lot of policy change that's come out of that movement building at the state level too. There's always this interplay between state innovation and federal response, and then federal the federal administration kind of opening doors and states stepping through it. So there's always this push-pull that works together, but to move us forward. But at the state level, right now, I honestly think this is more than 18, but currently we have about 18 state coalitions that we know of that have kind of more formal movements behind them. But there's a lot more that there's groups and states, I would say most states, that are focusing and thinking about food as medicine for a variety of reasons. And we've seen a lot of, capital P policy change out of this. So waivers, other Medicaid policy and legislation. But we also have seen a lot of kind of lowercase p policy, which is, technical assistance, infrastructure building, administrative changes. As far as 1115 waivers, we have about 13 states. We have 13 states currently that have approved waivers that that allow for the reimbursement of food specifically. And then we have about 3 states that have pending waivers. And I know we have some movements around the waiver front, but that's pretty big policy change right there. We also have a lot of movement around in lieu of services, and this is a particular flexibility that's allowed in Medicaid managed care, that allows managed care organizations to pay for services in replacement for state plan services. So often these can be, even transportation or health home aides, something that's not a formal Medicaid service, but would kind of replace a need for a Medicaid service. And now we're allowed to even use those kind of non-traditional Medicaid services to prevent the need for future Medicaid services. So 10 states currently use this policy pathway to offer nutrition services. The most robust one that I want to name is Michigan. They just released their final in lieu of services policy guidance last year. And so that's something that I'll be encouraging West Virginia to model after if we are interested in pursuing in lieu of services policy changes. And then, I just included some information about legislation that was up for this session. But every session, it's been growing and growing. So that is actual pieces of legislation and bills, but then also budgetary amendments too. And I have a much longer list of that I'm happy to share if you're curious. So just shoot me an email. And then we also have a lot of the movement at the national level too, that's supporting these statewide coalitions, and also especially focusing on federal policy change. Food is Medicine Coalition focused on medically tailored meals and medically tailored groceries. The National Produce Prescription Coalition, the Medicaid Food Security Network, which focuses a little bit broader, a lot on the integration between SNAP and healthcare, in addition to some food as medicine services. And then we have the private sector getting involved. We have the Milken Institute, we have Rockefeller, we have the American Heart Association. We also have a lot of grocers that are getting involved in this space too. So for state coalitions, they have been formed a variety of ways, and there's no wrong way. Of course, there's no wrong way, but there's really no wrong way to go about forming a coalition. Some have been formed, through collaborative products. So maybe they're calling folks together in the state to develop a report or do a big data collection effort, or even to organize an event. Virginia had a Food as Medicine Summit last year. That's kind of an example where they're not calling themselves a formal coalition, but everyone that's been involved in planning that summit is still gathering and talking about food as medicine. There's also, sometimes there's these policy opportunities that are happening. And so you're quickly gathering support or gathering experts in the state together to say, hey, how can we inform the development of these policies? And then also, if things are passed, how can we actually support the implementation of those policies? So that, might be 1115 waivers, it might be in lieu of services guidance, it might be pilot programs that are operating or trying to operate in the state. And then, if there's active policy, those campaigns too, to support pieces of legislation, budgetary action. And then sometimes groups are getting together and saying, hey, we don't know what's happening in the state, but we know that we need a plan and we want to push the dial forward, even if we don't have a report in mind or we don't have a policy opportunity right in front of us. We want to create those opportunities. So, groups have been formed, groups have come together to do some kind of collaborative strategic planning as well. We've seen that in New York. We've also seen that in Florida. And then I'll also name Oklahoma too, has a really great strategic plan that they've been socializing. And then really, the goals are very similar across all the states. It's really, how can you gather folks together to make the case for food as medicine in your state? Both to each other, both to policymakers, any way you can make the case. And a lot of that comes from increasing visibility of programs through inventories, one-pagers, op-eds. You also want to highlight the stories of these programs just like the stats are really hard to feel, the impacts of the program are really hard to feel unless you're creating an emotional story that goes along with that too. And there's no shortage of those. We know how food impacts people. Um, Additionally, how can folks come together to educate policymakers? They're often looking to us to say like, hey, we support your broader idea, but like, how do you expect us to do anything about it? What are your ideas? And so we often, as state coalitions, have to go to them with our ideas and kind of talk to them about how to move forward with it. And also showcase that it's not unique, that it's maybe been done in other places. Additionally, we have a lot of questions around implementation. And so, program implementers are constantly looking for additional guidance and technical assistance there. And there's so many states to learn from. So that's another big goal. In addition, we know the evidence base is really important, and we especially know that the local evidence base speaks volumes to local policymakers too. People want to know what's happening in their state to their constituents. And then, like I also mentioned, creating policy opportunities and building support. So this is overwhelming, like much of the deck, but here are some examples of products that coalitions have made. So we have a lot of food is medicine one-pagers on here. Up at the top, we have the one-pager from DC, and then we have Michigan, that talks about produce prescriptions and especially the connection between produce prescriptions and local agriculture. We also have a flyer for the Food is Medicine Summit that was put on in Colorado last year. We also have right underneath the flyer, this is a screenshot of a slide deck from California. California's Food is Medicine group has been leading the technical assistance around implementing their 1115 waiver. So they've been the liaison between programs and Medicaid staff. And then Oklahoma, that's a snapshot of their strategic plan. Food is Medicine Massachusetts, we had this group create we realized that there wasn't an inventory of services, especially one that healthcare providers could use. The services weren't really showing up in things like Aunt Bertha or other kind of referral networks. And so we created our own, which was a really cool project. And then we have landscape scans. In the right-hand corner, we have the New York Food is Medicine Project and their policy recommendations and kind of like their advocacy agenda, if you will. So we've had a lot of national policy change. And, this is a lot to take in, but the bolded text is really kind of national movement. Or federal level movement that has continued to open these really big doors for the states to seize opportunities and walk through. So we had, the NIH focusing on food as medicine. We had some of the earlier waivers back in 2016 that were happening in Massachusetts. We had the White House conference. In 2023, we had the Veteran Administration, the VA, launching a produce prescription pilot, and we also had the Indian Health Services launching a produce prescription pilot. We also had a slew of guidance that was coming out of the Biden administration that was just continuing to support food as medicine, which was really fantastic. And then we also recently had some federal legislation that was introduced. So the movement kept growing and kind of growing, and the doors kept opening and opening. But we know that with a new administration, we have a bit of a shifting landscape. So we have a new agenda, and that brings across some new challenges too. So we know that, especially recently with the bill that was passed, there's major rollbacks to Medicaid reimbursement pathways. The CMS has been rescinding the guidance around social determinants of health, which definitely poses some challenges for us. We also know that value-based insurance design is kind of winding down. That was a healthcare model that allowed for the integration of like value and kind of focusing on broader health needs. So that's winding down. We also know that there's just major reorganization happening and staff cuts. We also know that there's major, there's SNAP and Medicaid. We have major decreases in funding. And then we also have work requirements, and we also have limits on like how much the federal government is willing to support states in SNAP and Medicaid. And then, of course, we just have some conflicting kind of dietary and regulatory policies that are happening, times where agencies are supposed to be kind of have a lot of authority and within a broader context where all agency authority is trying to be limited. So it can be a little bit confusing here. But at the same time, there's also a lot of opportunities that are happening. It just requires a little bit of a shift in thinking too. So we have Make America Healthy Again. There's a lot of alignment with MAHA in this. The broader message of hey, look, especially in relation to our food system, hey, look, something's not working. We need to do something different. And food as medicine is something different. We also have a focus on maternal health. And we know that food as medicine interventions really support, pregnant people and new infants. We also have this focus on private-public partnerships. And a lot of food as medicine interventions are kind of just that too. Additionally, a focus on farmers and agriculture, a continued interest in cost savings, this focus on local needs and local solutions, and then veteran food security as well. So how does this apply in West Virginia? Well, we have a lot of work to do here, but we had a slide in this deck earlier about capacity building. There's a lot that we can do in this space as a coalition through building cross-sector partnerships, educating healthcare providers, deepening relationships with decision makers, creating a unified, strong voice, and making the case for food as medicine, developing an advocacy agenda, or at least a strategic plan on kind of how we're going to move forward here. Additionally, there's a lot of infrastructure and research to be developed. So we can provide guidance and technical assistance to providers, especially around implementation. We can build and enforce food as medicine standards in the state. We can build program inventories. We can implement small-scale pilot programs, and really focusing on small wins, like even how does food insecurity screening and making sure that that's universal play into the success of connecting folks that are food insecure with food. And so, there's also some opportunities in the healthcare system itself, especially Medicaid. West Virginia was chosen as one of 15 states to participate in a 10-year CMS pilot called Transforming Maternal Health. It's a new kind of model of looking at maternal health. And so there could be a lot of opportunities there to insert food as medicine, since we know the impacts in that area. We also have managed care contracts in West Virginia that are up for new procurement in 2026. That's an opportunity to adjust language to maybe encourage or incentivize the provision of food as medicine services. And then there's always in lieu of services within Medicaid managed care. It's great that we have some examples from other states that can really help us there. But it's a lot of choice. It's a lot of flexibility, which again is useful. And then, how are we thinking about food as medicine? And what's our focus here? There's a ton of opportunity to support West Virginian agriculture. And so, deepening those ties with agriculture, local food systems, being clear about how food as medicine programs can support our local producers. There's also, we know the barriers of folks that live in rural areas. So how are we, innovating in those areas to overcome those barriers through food as medicine? Through transportation or delivery, et cetera. Again, maternal health, and then of course alignment with MAHA. So there's a lot that is possible, and that's what makes me so excited about West Virginia. And it is, just as you're probably feeling now, it's kind of overwhelming, the amount of directions that we can go and the things that we can do. So shockingly, I'm not too far over time, which is good. But I did have 3 questions for you, and I'm really hoping that you can put your answers in the chat, and we'll go one by one so that we can give pause to this. And then I am going to call on some folks to kind of say more about maybe what they put in the chat. So if folks are comfortable kind of speaking out loud, then feel free to raise your hand on Zoom, and I can also just call on you for that. But the first question, and we asked this at the beginning, but I'm going to ask it again now, especially after this presentation. What concerns you or worries you in this moment related to food is medicine? Funding and sustainability, yeah. Holly, can you talk a little bit more about where your mind goes with access?
Yeah, so just basically if it, do they have a ride to the food bank? Do they have a way to get to the place that has the food?
Yeah, we know transportation is one of the primary barriers.
Mhm.
Definitely. I'm also curious about what makes people feel, hopeful. Like what feels opportunistic about this moment? And how do you see that in West Virginia? And Jeff Tanner, you're kind of smack dab in the front of my screen, so I'm curious if there's anything that you think about here when you think about kind of what does feel like an opportunity.
Well, it's going to save me a lot of typing, so I'll just go ahead and say it. We rank so poorly in so many of the health, you know, hypertension, diabetes, COPD. We rank so poorly that there's just a great opportunity that, you know, if you can make it work here, you can make it work anywhere. So if we can get the point where we can do good data collection and set up good either pilot programs, sample programs, research kind of based data collection centers and be able to collect that data and collect it from multiple centers to show that there is some change. Again, like I said, I think if you can make it work at here, you can make it work anywhere because there's so many challenges geographically, transportation, those social determinants of health. We're nothing but a food desert everywhere. So I think there's just a lot of opportunity. It's just I think there's going to be it'd be nice to be able to get something like this together where individuals can work together and collect data together and say, here's what we're trying to do and kind of learn a little bit each other and then try to build off what each other's trying to do.
Awesome. Thanks so much, Jeff. Kimberly Carr, you're also on my screen. I'm wondering if there's anything that brings you hope in this space right now.
Yes, thank you so much. I actually can't talk because I'm just
Oh, I'm so
on.
sorry. We can skip
No,
you.
it's okay. Thank you so much. But I would say I agree with Jeff, and I'm gonna try to talk over with the data collection. I'm representing the West Virginia, um, University, the Institute for Community and Rural Health, and I'm a part of the Nourish West Virginia initiative. And food is medicine. Like you said, it's not duplicative. It's in support of West Virginia Food is Medicine Coalition. And one of the things, I'm a research associate, so one of the things that we are really trying to do is build a collaborative rather than a coalition and seeing what that data looks like. So, Jeff, I'm quite sure you're familiar with Dr. Megan Govindan. And if not, it would be great to connect with her so we can see what that data collection looks like. I wish I could say more, but my voice is just gone.
That's okay. I'm so sorry. Thank you so much for sharing.
No problem.
Kelly Burns, I'm also going to call on you and see if you have any thoughts here.
Hi, thanks. When I think about, so I'm a producer in West Virginia. I'm your food grower, one of them. And I grow food that people aren't even willing to try. It's a pepper that doesn't look like a normal pepper. So West Virginians are just ingrained in how we do things. I mean, we've always done it wrong this way, and we ain't changing. So getting the information out. We are doing a pilot program, the Pharmacy West Virginia, in Nicholas County, and it is going well. So I'm excited about that. So I think I'm excited to be a part of this group, and learn and kind of have a ripple effect through my county and through the state.
Absolutely. Thank you so much for sharing that, Kelly. We definitely we need your growers to be a part of this. We want to be integrated in that. It's really, really, really critical. We're stronger together. And I know we just have a few minutes left here. So, last question for folks. What do you want to know more about? We're going to be having these meetings, and we're going to be having a lot of opportunity to kind of discuss various topics or policy opportunities. So we're curious, what kinds of speakers should we be bringing in? What should we be thinking about? Data collection, veteran food insecurity, fantastic. Absolutely. Yeah, does anybody care to share with the group also? Thank you for tolerating me calling on folks. Shane?
Yeah, I was going to say, I just wanted to say one thing. I think data collection is the future. That's where where the pavement hits the road or whatever, or the tire hits the pavement. I think that the more we can have a baseline of hey, these are the 8 or 10 things we're trying to get, because then, my group of 100 can be amplified by your 100 or your 20, and then it turns into a massive study group because we have this baseline of data or whatever. So that's my hope. And what I want, just ways to collaborate with that.
Thank you so much, Shane. Absolutely. Stacy?
Hi, I am here in Pocahontas County, and we have received some funding for a food shed project. So it is basically just expanding access to food in our county through multiple different ways, and we're building a community kitchen.
Fantastic.
So we have lots of things happening on this front. Currently, we also do the pharmacy program here in the county. And then we're also working with a doctor that started at WVU but is now at Duke to help build our diabetes community and support groups. So we've got lots of data coming because we're in year 3. But that's our thing, is collecting the data and, knowing exactly what to collect, what people, funders especially want to see, and how do we record that change that's happening, most efficiently. So data collection is something that, we've all kind of struggled with on that front. So that is our goal, is to learn a lot more about that.
Great. Awesome. Thank you so much. All right. And we are at time, so I'll pass it. Who's wrapping us up today?
I can wrap us up real quick.
Thanks, Ryan.
So we got some, just reiterating some dates that we got coming up in the immediate future. Our next coalition meetings in August. We have our philanthropy focus group coming up. More information about those, as well as RSVPs for our in-person meeting in September. Be on the lookout for that. I do have one short ask. Please take a couple minutes and complete a short feedback survey from today's meeting. I did drop that in the chat. And then be on the lookout for a link to our recording from this meeting and all our associated materials. So thank you so much for staying with us. It's really a privilege to get to work with this group. Thank you, Kristen, for your presentation. Thank you, Danielle, for presentation earlier. And I hope you all have a great rest of your day. Thank you so much.